Hi, this is Brian Kim. I'm going to share with you this case of a patient who has chronic angle closure glaucoma. This also led to posterior synechiae. And actually, this patient has a very small eye. And when I examined this patient, she had a very, very shallow chamber. Actually, no real discernible chamber to be able to do safe cataract surgery. And on top of that, she had a dense white cataract. And so I don't like to stick needles into the sclera to do a sclerotomy and vitrectomy in these cases because, again, the pars plana space is really not as defined in these small eyes. And so we gave this patient mannitol and we just prayed that things were going to go well. And so this is the case. You can see the posterior synechiae, the white cataract. I used a corneal marker, which will help me to center and size my rhexis. I'm making my side port incisions here. And after all that mannitol, this patient did have some level of chamber, but again, it's really quite shallow. I'm injecting some intracameral lidocaine with intracameral epinephrine. And then I'm going to inject some intracameral air, which will help me to paint the anterior capsule surface. I'm injecting intracameral trypan blue. And then I'm injecting some dispersive viscoelastic. Again, this chamber is just not really very good. And so I'm going to do my best to keep it as formed as possible. This is the triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove, tunnel, and then enter. I inject some more viscoelastic, and I'm actually going to push viscoelastic as I do the rhexis. As I tried to make the rhexis, I felt a little bit more comfortable instead of using the puncture style technique to use the cystotome. So I go ahead and switch, use the cystotome, and as I'm pushing the viscoelastic with the cannula, I start to make my rhexis. I'm actively pushing the viscoelastic to keep the chamber formed as I'm performing the capsulorhexis here. You can see the rhexis wants to go out, and so I'm actively pulling back in order to keep the rhexis in good shape. And I pull backward as needed as I'm making the rhexis. Again, simultaneously pushing the viscoelastic with the cannula. Okay, good. So thankfully that went okay, and there's no radialization of the rhexis. This is the Capsulorhexis hydrodissection technique. I place the cannula out under the rhexis edge contra-incisionally, point it down, get a nice wave, and as you can see, the lens spins nicely here. It's not very adherent to the bag in this white cataract. Irrigate the surface of the cornea, lifting the incision with the chopper, going in with irrigation off to minimize Descemet's trauma. Removing the surface epinuclear material, placing the chopper under the rhexis edge contra-incisionally, placing the figurative vertically sub-incisionally, bringing both instruments together, and with mechanical forces, I'm trying to crush and bisect the lens. I'm not quite so sure I went all the way through, so I try again. And this time I feel like there was a better separation of the two heminuclei there. Placing the chopper around the right heminucleus, pulling centrally toward the figurative, and I bisect the right heminucleus with the cross-chop maneuver. Using a little vacuum to lift that first quadrant up, I get it up out of the bag, using the chopper underneath it to get around it, and then crushing and bisecting the lens with mechanical forces. And then I'm also finding the lens piece very carefully here. You can see this pupil is just flopping around like crazy. Again, I think it's because of the flaccid iris is due to the angle closure glaucoma. That high pressure does cause ischemia to the iris. But with these maneuvers, I'm able to very carefully and systematically disassemble the lens by keeping the ultrasonic energy and vacuum to a minimum and doing all the aspiration of the lens pieces in the safe zone in the middle there. I decided to come out and I'm injecting some more viscoelastic to push the lens back and coat the corneal endothelium. Turning the second heminucleus in front of me, placing the chopper around the lens piece, bringing it towards the phaco tip, which is positioned deep in the bag, bisecting and crushing the lens with mechanical forces. Placing the chopper around that third quadrant, pulling it centrally toward the phaco tip, again, crushing and bisecting the lens with mechanical forces. By implementing mechanical forces as a primary method to fracture the lens, you can see the CDE is always low in my cases. But it does mean you have to be comfortable with maneuvering the instruments within the capsular bag and not being fearful that you're going to rupture the capsular bag during these maneuvers. When you become more comfortable with these maneuvers, you're able to handle a whole host of clinical situations in tough cases, because mechanically fracturing the lens pieces is much less complicated than trying to use high vacuum in a situation when you have an anterior capsular tear or a posterior capsule rupture, or even when you have vitreous loss, small pupils, iridodialysis. Trying to use high vacuum and quite a bit of ultrasonic energy can lead to more complications, in my opinion. You can see this is a dense lens, and so I'm periodically coming out. I'm injecting some more viscoelastic to push the posterior capsule back and to coat the cornea. Because this chamber is so shallow, the posterior capsule is wanting to come out. And also because this is a white lens, there's no significant epinucleus to cushion and create a barrier between the posterior capsule and my phaco tip. And so pushing that posterior capsule back with the viscoelastic is helpful. So again, I'm using mechanical fracturing forces to bisect the lens pieces and crushing them between the two instruments. I'm being careful to use sparing amounts of vacuum to lift and grab the pieces up and then crushing them between the instruments. So now I have the last quadrant in the bag. I'm rotating it with the chopper. Without using any vacuum, I'm just positioning the two instruments around the lens and then trying to crush it. Again, it's difficult to appreciate because this chamber is so shallow, the posterior capsule is coming up towards the phaco tip. And so this is the reason why I'm going in with a lot of viscoelastic to push the posterior capsule back as I try to get rid of this last piece. So with the eye full of viscoelastic, I'm able to position the instruments to crush the lens, bisecting the lens with mechanical forces, making them into smaller and smaller pieces, Once the piece is close to the tip, I go ahead and activate the vacuum and ultrasonic energy in order to remove the pieces and not removing the viscoelastic. You want to keep the tip right over the lens pieces so that you're removing the lens pieces and not the viscoelastic. So here's the final pieces. I have the chopper deep in the bag as I'm trying to carefully remove these last fragments. And I'm trying to protect the cornea by not using high ultrasonic energy. And so you can see I'm very carefully and slowly removing those last pieces. So I take the chopper out, push BSS in, take the phaco tip out. You can see as I came out, the iris came out here. So I'm trying to relieve the pressure within the anterior chamber, do the paracentesis incision, and then I'm able to relieve the pressure and push the iris back. I go in with irrigation off and then activate irrigation. You can see that the capsule is flopping around, and there's probably some weakness of zonules, especially with the angle closure situation here. So I switch to the polish mode very quickly as I'm polishing the cortical material from the bag. When you're dealing with prior angle closure with posterior synechiae, you do have to assume that the angle closure caused some damage to the iris as well as the zonules. And so you can have a floppy iris, you can have weak zonules. So during INA, you can actually see that the capsular bag is weak. So you don't want to be too aggressive with cortical removal and grabbing the capsule with the INA accidentally here. I'm using the cannula to pulse the subincisional space. You can see some cortical material came out, filling the capsular bag with cohesive viscoelastic now. And go ahead and sweep under the rhexis edge to help remove the lens epithelial cells. Since this is an eye with potentially weak zonules, white cataract, I usually go with a 3-piece lens in those situations. So I'm going in with the 3-piece lens, pushing more viscoelastic to fill the bag. Point the barrel to the left. Let the leading haptic be delivered correctly. As the optic comes out, you want to rotate your wrist counterclockwise, 90 degrees, which comes out straight and correctly. And then I'm using the Maltzman to dial in the trailing haptic in the bag. So here I'm using some micro scissors to try to open up the rhexis a little bit because the rhexis was a little bit on the small side. So I cut the capsule there, and then I'm using rhexis forceps to go ahead and widen up the rhexis a little bit here. So I go in with irrigation off, activate irrigation, go underneath the lens, removing the viscoelastic from within the bag. And then the anterior chamber, and then I'll hydrate my incision. So again, this is a patient who had chronic angle closure, posterior synechiae, no anterior chamber whatsoever on examination. In these challenging cases, you can have weak zonules, you have a white cataract, of course, and in the small eye, you just don't know where the pars plana is, and so you don't really know where you're able to make your incision. And so instead of doing a vitrectomy blind, we used mannitol, which worked exceptionally well. Again, the chamber was shallow, but it was not nearly as shallow as it was in the office. We were able to very carefully and systematically disassemble this very dense lens, which had a very shallow chamber and a posterior capsule that wanted to keep coming forward. Again, with the white cataract, there's no significant epinucleus, and so as the lens is coming out, everything is coming out even including the cortex. And so there's nothing buffering between your phaco tip and the posterior capsule. The posterior capsule is wanting to fly out. That in conjunction with the weak zonules, there's a lot of laxity to the posterior capsule. And so I dispensed a lot of dispersive viscoelastic to push the posterior capsule back. And I did it on multiple occasions. I used mechanical fracturing techniques, which minimizes ultrasonic energy in vacuum as well. And so I was able to disassemble this lens relatively easily in a very tough situation with these techniques. So I hope this was helpful to you, and I thank you for your attention.